All right, welcome to part 3. And this is actually, we should title this one The Physiologically Difficult Airway, because that's pretty much what we're talking about. That's
Right.
all we cover in this.
Well, a little bit of surgical airways just at the end, just to kind of round it out.
Awesome. And but this really is probably the most important part of safely RSIing patients, and also probably the most neglected
Yes.
by those who don't know. So let's get started.
Our next category of difficult airway is the one that's probably overlooked and not talked about enough.
This is one where I feel like we get overconfident, paramedics that think, oh, I can RSI. Like, all I got to do is push meds and stick a tube in. And
Yeah.
this is where it will bite you.
Yes, because if you're not aware of this, I created this little picture because in my head, this is how I view it. I am at the peak, and if I tip off one side, the patient desaturates. If I tip off the other side, they go into cardiovascular collapse. So I have to keep a very good balance. And these are patients who are very sick chronically, or they're in a very sick acute problem right now. And we have to manage that. This is the patient that you resuscitate before you intubate. And we can't stress it enough. So let's talk about how we address a physiologically difficult airway. So this graph is a good representation of time to desaturation for different populations of our patients. And this is really the basis for our physiologically difficult issues on the saturation side. If you look at this, the horizontal axis is time, the vertical axis is their saturation, and it's their SaO2, slightly different than their SpO2, but we don't need to hash that out right here. The idea here is that they have been pre-oxygenated very well, and they're at 100%. You can see right where that line starts. And on a healthy patient who you've pre-oxygenated well and you've washed their nitrogen, which we will talk about, they have upwards of 9 minutes before they get below 90%, which is a lot of time.
Yeah, and this is a healthy patient, healthy lungs.
Not an increased consumption.
It's actually a 70-kilogram white male patient who happens to be in the military, because that's where they run all these tests.
That's where they run these tests. So most of my patients that I'm managing their airway do not fall into that category. So let's look at some of these other things. A normal child, look at how quickly they will saturate, even with pre-oxygenate. Desaturate. They will drop at 4 minutes. They're on their way down, and it's a steep drop. It's a cliff. So
4 minutes. I mean,
that's
4
still
minutes
a lot
is
of
still
time.
a long time.
But you don't have their consumption is higher, and you just don't have the same window as you do with an adult. And then a moderately ill adult that's 70 kilos, again, we're looking at a patient that doesn't really fit a lot of our population, but if they're moderately ill, so they're not starting off at 100%, we've all had those patients where you pre-oxygenate, and the best you're getting is 94, and you're like, I don't like this. Well, this is that patient. You still have a good window of time if you've done your due diligence to pre-oxygenate. And then let's look at our population that falls off the cliff the fastest, and that is an obese adult. So someone considered greater than 120 kilos approximately. So even if they're pre-oxygenated at 100% and you've done all your job, they've got less than 4 minutes before they're at zero. That's significant. And I feel like this is a huge portion of my patients that I see, just because they're the ones that call 911. They get in, they fall, they have chronic, comorbidities that affect their everyday life. So consider this chart whenever you're approaching airway management. When we talk about this, our obese patients, those are the ones that are going to desaturate the fastest, even when we've done our best to pre-oxygenate them. Our children, they're our second population that will desaturate the fastest. So keeping that in mind. Now,
Also, the two typically most difficult.
Yes.
I guess kids aren't always difficult.
Well, but I think difficulty arises because we have anxiety about managing very sick kids. We do. So another element of the physiological difficulty that we run into is the volumes. And just this is more to explain your volumes versus your capacities. Lung volumes, they're not overlapping. There's specific amounts of air during phases of your respiratory cycle. So the capacities are the sums of the combination of different volumes that are standard. Looking at this, if you've not seen this chart before, it shows you capacities and volumes. I feel like it's very helpful. The capacities, your total lung capacity is everything. So it's everything from nothing all the way to the full inspiratory reserve. And if you look at these ranges in mLs that are here, there's depending on how tall your patient is, they're going to have different volumes. But capacity can change depending on what's going on with your patient. So they might have a reduced expiratory reserve volume. They might have a reduced inspiratory reserve volume if they've got a restrictive issue, which this is all going to affect their ability to oxygenate and ventilate. So in the physiologically difficult airway, there is one mnemonic that you're going to be taught to remember, and it's the crash mnemonic. And these are all reasons why patients either become hypoxic or they move into cardiovascular collapse when we take their airway. So the first one is consumption. And if they're in a high consumption state, so sepsis, acute respiratory distress, excited delirium, thyrotoxicosis, pregnancy, or just children, they are just high consumption, we're going to optimize our pre-oxygenation and our apneic oxygenation. And we'll talk about strategies for that. But you're going to hear this over and over. Optimize your pre-oxygenation. Right ventricular failure. When we talk about people in what do you think of with right ventricular failure, Josh? Because that's not something in the field. In the 911, I feel like not everyone is like, oh, well, that's what we're doing.
Right. So right ventricular failure, this is going to be someone who needs is dependent on preload.
Yes.
Because that's what your right heart needs preload. That's why someone who's having a right ventricular infarct, that's why we don't give them nitrogen or nitroglycerin. Because we take away that preload and then their cardiovascular collapse.
Yeah. The right ventricle is it has very little reserve to overcome the afterload if something's pushing back. So a pulmonary embolism, or if they have pulmonary arterial hypertension, which you won't know in a 911 setting necessarily, but
they're overcoming that because of their preload.
Yes.
So which when we start pushing these medications and stuff, and introducing positive pressure ventilation, all of a sudden we're reducing preload to the right side of the heart.
So consider that. The ways to mitigate making that worse is, again, optimize your pre-oxygenation. If you're in a transport setting, you can think inhaled vasodilators to help with that pulmonary hypertension. They might need vasopressors before you approach their airway. You might need to do that. And then choosing your induction agents very carefully is a consideration. The third one is acidosis. So acidosis, when we talk about that, I think we don't always recognize it in the field depending on their presentation, but like a diabetic ketoacidosis is pretty, I think, obvious. Yes. But lactic acidosis, severe sepsis, once they have crossed that threshold, major trauma, salicylate ingestion can create this. When we have a severe acidosis, they're at risk of us managing their ventilatory status because that's their compensatory mechanism. So we might make things worse.
Yeah, once all of a sudden they're barely keeping their pH at a sustainable level, and all of a sudden you take away their ventilatory ability, now their pH is going to shoot up through the roof.
And they're very sensitive.
Or sorry, shoot down through the floor.
The acid is going to shoot up.
Acid's going to shoot up.
They're very sensitive to hemodynamic instability as well because of their condition. So we definitely need to be aware of what we're doing with these acidotic patients. We can try to correct the underlying issue, definitely minimize any time of apnea, because that's just going to make their acidosis so much worse. And for those of you who haven't done RSI, once you push the paralytic within 30 to 45 seconds, it's all you.
Now they are apneic.
Yeah,
right?
You do not have any time with these patients. And every, I think, agency has policies surrounding this if you have a ventilator. But like in my agency, if we have a patient, let's just say in DKA, and they're breathing at 42 times a minute and it's deep and fast, I need to try to match their minute volume. So my ventilator will scream at me if I say 42 times. It's going to be like, no. But I can.
And I have heard situations where medical personnel are like, oh, they're breathing too fast. So they paralyze them,
bag them down,
put them on the ventilator and set it at a normal rate. Well, they were breathing fast for a reason.
Yes.
And now they're going to die.
Yes. And it will happen quickly. So we try to avoid mechanical ventilation in these patients, but you should have some standard or policy for matching their minute ventilation to help maintain their compensatory mechanism.
Yeah, there was a point where this was years ago, where you wanted to avoid ventilating them during the apneic period, so you'd hyperoxygenate them, and then so while you're letting them get completely paralyzed, you just let them chill. And we still do that, but not when it's someone who's dependent on their respiratory drive to maintain their acid-base balance. And so because by bagging them, the thought was, oh, you're increasing their risk for aspiration, so don't bag them during the apneic period. But they've debunked that. So if needed, you can bag your patient during the apneic period in a patient such as a DKA patient or overdose on, aspirin or something like that.
And that's really what makes you a clinician, is understanding the physiology of what's happening. And then our S is for saturation. And patients who have saturation issues generally have an acute respiratory problem, or they are an ARDS patient. They've got a COPD problem, pulmonary edema, anything like that, where even pneumonia. So they already have a problem either with the gradient of the oxygen across the membrane, or they have a problem with their ventilatory ability. So we need to make sure that in accounting for, we optimize pre-oxygenation and their apneic oxygenation. And this is so important because they don't have the same gradient that a normal healthy person has.
So let's talk about that gradient really quick.
Okay.
So in the alveoli, right, the oxygen flows into your capillaries because you have a pressure gradient. You have higher pressure of oxygen in the alveoli than in your capillary blood that's returning from having just delivered its oxygen throughout the body. The higher that gradient, the more oxygen, just like on a fire engine, right? Like the higher I pump my pressure, the more flow I'm going to get out the end of my nozzle. So the bigger the difference between the pressure in the alveoli and the lower pressure in the capillaries, the more oxygen's going to flow, the faster it's going to flow. And so that you have to maintain that gradient. And that's why let's see, at this point, we've already should have talked about this in the class, but at high altitudes, right, if you have sudden decompression of the cabin, they say put your oxygen mask on first, right, before you put it on your child. And that is because as soon as you take one gulp of that air that has a very low oxygen content,
reverse the gradient.
Yeah. So now you've got to lower that one breath. Now the oxygen in your alveoli, the pressure is lower in your alveoli than in the capillary blood that's coming back to the lungs. And so now you're actually going to off gas.
Yeah, you're
oxygen's
losing it.
Going the other way.
It's such, and that gradient depends on not just that pressure change, but also the thickness of the membrane, any fluid or mucus that might be coating the membrane.
Right. Which is why ARDS is so dangerous, because
scar tissue,
the inflammation, the swelling, all of that.
And it depends also on surface area. So if they have consolidation of their lung tissue where they don't have all the little healthy alveoli, they've got
little grape cluster looking things,
they have less
like emphysema.
Less surface area. So have that in consideration with your patient as you're approaching taking their airway. And then for hypotension, that's the H. If they're already hypotensive, we're going to go into this in a minute, but we need to resuscitate them. The hypotension could be caused, whether it's caused by sepsis, acidosis, or any of the things that we've talked about, or hemorrhage. We cannot pressurize their chest and kill all their preload and save their life. Like, that's just not going to work. So we've got to account for that. Volume resuscitate, blood if we've got it, early vasopressors. All of those things need to be on our radar when we're going to take an airway.
And I think some of these like cowboy practitioners, that, they're like, oh, they don't consider all of these crash. I mean, if you're learning RSI, this is probably the most important part of RSI.
You should not approach an RSI without running. Do they have high consumption? Are they in right ventricular failure? Are they in a acidotic state? Do they have trouble saturating? And are they already hypotensive? Because if you're not checking that before you push that paralytic and decide you're going to manage them, you might tip them over into death.
Yeah, you might put them right into arrest. And so, but, like I was saying, these cowboy practitioners are like, well, we've got pressors. We'll just do push dose epi, right? Oh, yeah.
Don't get me started.
Oh, if they go hypotensive, we'll give them push dose epi. Well, vasopressors are not effective when you don't have the preload, right? You have to fill the tank first before pressors are going to be effective. And so this may be resuscitate with blood or resuscitate with, and when we say blood, we're typically not pushing pressors in trauma patients.
Not typically,
right?
No.
Now, we do in certain situations, with traumatic brain injury, and they've already had their scans, and we know they're not bleeding, right? But sometimes in septic patients, they do get blood. They get to give them more oxygen carrying capacity and replace all that fluid loss through the septic process. But you're going to have to fill their tank up before pressors are going to work. So it's not just, they'll be fine if they drop, I'll give them push dose epi.
Yeah, no. And that's the thing. I feel like as a critical care provider in the field or in the transport environment, you need to do your best to understand the nuances of hemodynamics, because we are messing around with it. And we've got to understand it. We've got to be aware of that nuance. So remember crash. So pre-oxygenation is kind of our big, we stand on the mountaintop and talk about pre-oxygenation, but it really is going to save you so much trouble when you are taking a patient's airway. Just like we mentioned, you're filling up their lungs with oxygen so that there is a gradient there, even if they're apneic. You are washing out the nitrogen. So three elements of pre-oxygenation. You've got to have a volume of gas to work with, the replacement of that gas with oxygen, that's the denitrogenation, and then the availability of the volume to the pulmonary circulation, meaning do they have a VQ mismatch? Is the blood flow not getting oxygenated even with oxygen in the lungs? And those are kind of our three elements to look at with pre-ox.
And I think it might be in the next lesson we're going to talk specifically about pre-oxygenation.
Yes, yeah, we go through in
appropriately.
part 3. We go through the steps of RSI and how to do that in detail. But when we are talking about pre-oxygenation, we need to consider positioning, continuous passive oxygenation during apnea. And I hear people say high flow nasal cannula. This is not the time we get out our high flow humidified warmed cannula. This isn't, because that's a whole process to set up. That's for long-term use. This is, you can put a cannula on and crank that sucker up and you've got some passive oxygenation, because you're not going to be doing this for longer than a few minutes.
Well, and this goes back to that gradient. What you're doing here is maintaining a gradient. You can almost oxygenate a dead person, right? At least you can fill their alveoli up with oxygen and have that increased pressure gradient, so that if their blood was moving, you'd be pushing oxygen basically right into their blood. Now, if you're not ventilating them and you're just relying on that passive oxygenation, their CO2 is going to start to climb, and they'll get a respiratory acidosis if they don't already have one. But this is just oxygenating the blood by increasing that gradient. So during the apneic period of RSI, making sure that we're maintaining a big oxygen gradient.
Yes, and with that, gentle interposed mask ventilation for patients who cannot tolerate apnea. And those are all those patients we talked about that you are not to leave them apneic, because they will crash. So have a BVM there ready to provide some support during that apneic period.
I hope we're scaring you. Because you really should be scared when you RSI. You should be confident, but you should have a healthy respect for it. Yes. I have never RSI'd a patient that I wasn't a little puckered.
Well, it's appropriate.
Right, but I've intubated lots of patients in the field, who are in cardiac arrest. They're already dead. Mm-hmm. There's not, that pucker factor's not there.
They're already dead.
They're already dead.
Yes.
What's the worst you could do?
If you make them dead because of your actions, then we got a big problem.
When you take a person that's breathing and talking to you and all of a sudden make it so they can't breathe and talk anymore because of a medicine you push.
Yes, that you can't take away.
Yeah.
You can't reverse it. You don't have the reversal.
The responsibility is huge.
It is a huge responsibility. So, but that's pre-oxygenation. And then the next thing I want to talk about is our shock index. And this is something that I don't think it's talked about enough.
No, I think it's getting talked about more, and I'm glad you're bringing it up here, because this is something we should be using. I mean, just get used to using it in your every single patient,
even
so that it's second nature.
Yeah, like when I have a patient who I'm like, they're kind of like giving me a septic vibe. Like they're not full on crashed into sepsis yet, but I'm like on that threshold, like they're meeting the criteria right now. I want to know what their shock index is, because oftentimes they've got a pretty good shock index, even though they're like, hey, I just feel crappy. I just think I need to go to the hospital. Oh, okay, well, let's evaluate this. A pre-intubation shock index is, if they've got a high shock index, it's associated with post-intubation cardiovascular collapse, just straight across. It's directly associated. We have got to resuscitate these patients, because even if they don't go into arrest, it's associated with longer ICU stays, increased mortality later. And those are all things that we have imposed because we took their airway. So we need to be aware of that. So let's just have a quick little review of the shock index. So let me go back. The shock index is your heart rate divided by your systolic pressure. And a normal is less than 0.7. So like my normal systolic is about 110, 105. And my heart rate, my resting heart rate is 50 to 60. So I'm about a 0.5 shock index, just at my normal
We'll do the
state.
math here. Let's pause.
Okay.
Yeah, if your heart rate is 60, I have a calculator. I wish I was that good at math. Although this isn't that hard. If you have a heart rate of 60 and a systolic of 100, your shock index is 0.6.
0.6. Yeah. So think of that as like, oh, they're normal, less than 0.7. And if you need to quickly pull a calculator and calculate it because you're not sure, but I think it's recommended. I'm a fan of using all sorts of references. And if it's my kid that you're working on, please use your calculator.
It's crazy. We all have one. We all have one.
We carry it with
Always.
us all the time.
Can you imagine if back in the 90s, I just said to you, Rebecca, there will come a day where you will ne'er be without a calculator. That's the future of the world. And you'd be like, what is like math? Our survival depends on math? No, everything, your whole library,
will
it's
be
all
in
there.
your pocket. So let's go at the high risk of RSI collapse after RSI is associated with anything greater than 0.8 on their shock index. So this slide, now I'm going to give you some examples and you guys are going to calculate what they are. So here you have a patient, their blood pressure is 102/80, probably nothing that's like ringing a lot of bells. Their heart rate is 98. Everyone that's listening and watching, make a quick calculation. They have a shock index of 0.96.
That's not good. That's greater than 0.7.
Yeah. So this patient is at high risk for cardiovascular collapse post-intubation. So you wouldn't necessarily think that. In fact, I know a lot of providers that would be like, I'd be great with that blood pressure. Well, not always. Here's the next one. It
looks reasonable.
A little soft, maybe. You'd call that maybe soft, 96/65.
But I wouldn't anticipate this patient's going to rest on me in 2 seconds.
No. But their heart rate's the same as the one before. So what's their shock index? 1.2. Shock index greater than 1 is associated with a very high mortality. So, and that's in our trauma patients, just without intubation. So we need to really resuscitate this patient. And then our last one is our classic 120/80. That's like considered the textbook blood pressure. And their heart rate is 114. Again, probably no glaring red flags right here, but that is a shock index of 0.95. This patient needs to be resuscitated. And I would dare to bet that there's a lot of providers that would think, no, they're great. They're fine.
Yeah.
You have got to, if you're going to run RSI, I feel like it's imperative that you calculate a shock index on that patient and put it in your narrative, put it in your documentation that you had that in consideration. Because if things go south, you will need to defend your actions. So, after that,
I would imagine with it becoming more of a used little tool that we'd start to see this as like a standard vital sign eventually that will be in our charting and would document it.
I would think so. I have zero issue with just putting it into my narrative that I calculated their shock index at this number. And that I accounted for it. But
maybe that's a little strong. Maybe it's not going to become a standard.
I don't know.
It's definitely something to keep in mind when we're now pushing these kind of medications.
When you read the Walls Manual, which is the kind of the gold standard.
The Bible.
Yeah, for airway management, they refer to it repeatedly. So it's something to have in your, toolbox. The last part of this is the hemodynamics, and this little chart from the Walls Manual just kind of shows our goals with managing their hemodynamics. And it shows you in this diagram where our different pharmacological agents work and what they act on. So I felt like that's very helpful. But we need to replete their volume loss and reduce the unstressed volume and vasoplegia, which, depending on what pressors you use and what you're doing, that's how you'll manage that.
Tell us what vasoplegia is.
It is lack of tone in their vasculature. So it's kind of like the container has gotten a little loose and boggy, and it's not providing that.
It's had a few babies. It's
Oh my gosh.
things just aren't as tight and as they used to be.
Whew, I don't even know what to say to that. If they're unresponsive to fluid, because again, you're not going to have a direct measurement of their vasoplegia, but unresponsive to fluid is a pretty good sign that the container's not tightening up around it. So you're just putting fluid and it's just stretching out more. And then augment their ventricular performance. And so this is primarily done through inotropes. And if you're a ground agency, you might not have much other than epi as an inotrope. But they might need what we call inodilators. And that's in the pharmacology lecture. But just know that if that's your suspected problem with your patient's hemodynamics and you don't have any way to manage that, you might need to reconsider your plan, just because you're not going to be able to manage that if you don't have these inotropes and inodilators, because generally people carry epi and that's about it. If you're on a flight team, you probably carry something more.
Yeah, well, yeah, you carry a lot more, but dobutamine, dopamine, Levophed, epinephrine is commonly what we carried.
Which is appropriate because
vasopressin.
Those are the things that will help to manage that that ventricular performance. And then you've got to consider mitigating the effect of your induction agent. Etomidate is super safe, but it still has effects on your body, and it can affect their hemodynamic status. It's got some adrenal effects that have been
debunked.
They've been debunked. I mean, it does affect their adrenals, but it doesn't cause this huge adrenal insufficiency like they thought it did.
Right. And so just a quick review, adrenal insufficiency. So your adrenal glands release
your catecholamines.
Yeah, your catecholamines, but also your aldosterone
and cortisol.
Yeah, these stress hormones that help increase your body's ability to manage stress, right?
Right. And etomidate can reduce your arterial elastance and cause some subtle hypotension. Ketamine, which is thought to be like, oh, it's so great, it actually can be a myocardial depressant depending on where this patient is on this continuum of their adrenal exhaustion or their shock state, essentially.
Yeah, and so we're talking about etomidate this is a mainstay for an induction agent in RSI. So,
and we're going to do that on part 3.
You're hearing it now,
but this
is a drug that you are going to get very comfortable and use a fair amount if you're doing a lot of RSI.
So the last thing is protect the right ventricle, and if you're hypercapnic and hypoxic, it's going to create pulmonary resistance. That's just it. That's just how your body works. And so you're going to load that right ventricle unnecessarily if you put them in that state. So we protect the right ventricle by avoiding hypoxia and hypercapnia. Because then if they have hypotension on top of those other two elements, we are setting them up for arrest. So that's just something to consider. Gastric decompression, if they've been BVM'd for any period of time, this is a go-to for me. And I have my, I question whether it really helps. I don't know. I think it does. But I just put an NG tube or an OG, like I put the NG tube down the oropharynx, just because.
I think it immediately transforms into an OG tube when you do that. Yeah, anytime. So, and general paramedicine, this isn't like necessarily a common thing. Like everyone's going nasally, and if you want to put an NG tube in, that's fine. But typically, and you'll see this in the ICUs, is once the patient gets intubated, you just take the gastric tube, stick it in the oropharynx, run it down the esophagus, and then tape it to the ET tube. Having that giant hose hanging out of their nose for any extended period of time causes tissue breakdown and infection and stuff like that. So in the ICU, we usually keep those in the oropharynx.
And here's a confession. Rebecca put them in the nose for a long time.
It's not bad.
And then I was with Josh, not on a call, but Josh was like, why don't you just put it in their mouth? And I was like, that's a great idea. Like, you've got a tube in their trachea. It's just, there's only one place for it to go. Yeah. And so that's since that conversation,
you feel like it's easier going in the mouth?
Oh, it's so much easier. Yeah. It's so much
less
easier.
risk of trauma and bleeding.
Mm-hmm. And you don't measure it exactly the same. So remember that you have to measure a little different. But it decreases the risk for aspiration. But once you've got their airway like solidly managed, you should be good for that. But it increases their thoracic space because you're reducing the pressure from that bloated stomach up on their diaphragm that reduces their ability to have ventilation. So, and just remember, nasogastric placement is contraindicated with facial trauma.
Yeah, everyone's seen that CT scan of a wound up
curled
NG
up in
tube
their
in the ventricle.
That's scary.
Of the brain.
Mm-hmm. All right. And now surgical airway management. This is one of those topics that I think providers in the field like to talk about, like it's like super cool. Like, this is such a cool call.
Fall back.
Yes.
Fall back. Crike 'em. Yeah. No big deal. We got this.
But I think this should be given the utmost respect for how dangerous it is. I think that, yes, this is a last resort because we got nothing else.
It is this is the last resort.
So yes, they're going to die without it. So you do have that, but keep in mind, they've got to have a total upper airway obstruction. Their tracheal intubation is not possible. You're unable to oxygenate or ventilate with the BVM. There's no other method to oxygenate these patients. The acronym that I learned is CICO or CICO, or however you pronounce it, but it's can't intubate, can't oxygenate. Those two things have to be present, and then you consider your surgical airway. And it doesn't mean just one. So if I can't intubate, I might be able to oxygenate them other ways. So I tell paramedic students,
which honestly, I think this is a time that crikes do get done, is they can't intubate, even though they can oxygenate them just fine.
Yes.
And they're like, hey, let's crike him.
Right. And I tell paramedic students this, and I just say, a crike is not a rescue for your crappy intubation skills. Like,
I love that.
That's
got to be a bumper sticker.
Like, if you feel like, I can't get the tube, let's just crike them, then you're on the wrong page completely. If you can't BVM them or use an extraglottic device to ventilate them, and you haven't done your whole process of positioning and all the things, and then you can't intubate, that's when we consider a crike, not just because we can't put a tube in their trachea. So
I won't tell you the whole story, but I was in a situation. I was a brand new flight nurse. Things went south really fast, and we happened to have this physician who's super awesome physician, because I know him, but he was on the scene of this, and everything went south, and finally I'm like, we got to crike him. Nobody is getting criked today. And then,
that's what he said.
Yeah. We ended up not, anyways.
Well, just know that some providers, you might work with a provider that's their like knee jerk. And it's not, I'm not saying I'm not going to consider it, because honestly, if anyone on scene suggests it, I'm going to run my little check to see if we need to do that. But it doesn't mean that we're just going to go for it. Like, recognize you have to have proper indications for this. Contraindications would be a transected trachea, although I did hear a story just the other day about a girl that had cut into her trachea, right at the crease of her neck.
Oh, we have a name for that, remember? At the hyothyroid junction.
Yes. So she had cut it.
That's where you do the Colombian necktie thing
No.
and pull the tongue down through it.
No.
Leave it hanging,
but
like a necktie.
If she kept her head down, she could actually breathe and almost phonate. But when she lifted her chin, it was no longer connected.
You ever see Braveheart?
Yes.
You know where the Lord cuts his wife's neck? If only she had put her chin down. She could have breathed.
Yeah, I think there's a little more there. But they ended up criking her, even though I was like, couldn't you just put it in where she cut it? Like, that was my question, is like, could you? And he goes, no, like the minute I tried her vocal cords, she cut right above her vocal cords. They just would like slam shut. And it was like reflexive. So he's like, I just went down and cut where we're supposed to cut. So transected trachea might be a problem.
A relative contraindication, but
anterior expanding hematoma, that sounds a little bit like our story about the Cosmo cougar.
Cosmo. All right, here we go. I put it in for you.
Ew.
Cosmo. Are you good?
You good?
I don't think so. All right, here's the aftermath.
Yikes.
So I did get permission from him to use this, but yeah, he broke his jaw, swelling up, and they shaved him. They had to shave him, all that hair off of him to get. But this is what Cosmo looks like without hair. All right, let's get back to the lesson.
Yes. Abnormal laryngeal anatomy. And we've talked so much about this. So just remember, if they've got surgical history, a tumor, all of that, you might run into being like problems with being able to landmark appropriately. If you have the ability to ventilate by other means, then we're not going to crank them. Nobody is getting cranked today. And then children less than 8 years of age have a very tiny cricothyroid space where that membrane lies. And really, the reason we hit that spot with adults is because of that thyroid cartilage. It creates a box of safety where our scalpel is kind of prevented from like wrecking other structures. And so when we're not using that I heard it called the cartilaginous cage once, but
I like that.
I like it too. But he's like, that's your safety cage. And
it's like the octagon.
So, but once you don't have that, you run a very high risk of damaging other structures. And most of the structures in our neck are relatively important. And so that's why children under the age of 8, because they don't have that and it's such a small landmark, we use a needle cric on those patients.
I don't want to brag, but mine's huge. Just saying.
Oh, I got to go back to this. Complications. Hemorrhaging, it is vascular. I know I've heard people talk like, oh, if you do it right, it's not going to bleed. Well, this is not something we practice regularly. So you need to approach it with the best possible technique, but be ready for hemorrhage. And I can tell you from the one that I assisted with, where a physician performed it, they handed me the yonker to suction, and there was so much blood. I just needed sponges. I just needed like 4x4s to kind of help because the suctioning wasn't really doing much. If the incision is too small, you will not be able to advance your tube. You will need to dilate that with the finger. We do this to the cadavers, so you will get a feel for this if you come to the cadaver class. Hypoxia, of course, they're already there if we're criking them. And lastly, you might lacerate their esophagus or their trachea and create false air passages into the tissue. And I even know of a story recently from an agency where they tried to cric a woman and the tube got past
in a false lumen.
Yes. And they didn't notice it. They didn't know. They were just ventilating into like
They're wondering
tissue.
why all while her skin's getting puffy.
I don't know. I just know that if you are not really careful with your technique, that's a potential. So this is a video of a real-time surgical airway. He is incising the tissue away so that he can articulate the membrane. Now, when he punches through, the air blows the blood out. You'll see that.
Goo.
Get his finger in the hole. He's got to hold the spot. So finger, then bougie. You're going to dilate the membrane out with your finger so that you can fit your tube in.
That's gross.
That's it.
Awesome. Thanks.
Okay. Needle crike, like I said, under the age of 8. If
Depends on the book too, because and the protocols, because our protocol in Utah is, I think, 12.
I think
under
it is,
the age
yes.
of 12.
They
But
go
I've seen books.
They go with anyone before puberty,
Yeah.
I think is the idea.
And you mentioned small. At some point, it begins to grow as they get older. But under 8, they may not even have a cricothyroid membrane yet. It's just those two cartilages are pressed together.
They're right together. So we have that in consideration. Now, when we talk about this in the cadaver lab and go through the techniques, we will talk about positioning, because your dominant hand is the one that is at the top of the patient toward their head. In a surgical airway, you want your non-dominant hand toward their head. In a needle crike, you want your dominant hand at the head. So you're going to position
Opposite
yourself.
side.
Yes, opposite side. And I know I've had providers I work with that are like, that's ridiculous. And I'm like, if you've ever tried to practice this on a mannequin or a cadaver, you'll know why. And so...
when I crike someone, which I have done once, I'm on the patient's right side because I'm right-handed.
Yes.
I've
So
never
your dominant hand's toward their feet. If
my
you're
dominant
criking.
hand's, yeah, okay. But you're telling me, this is actually news to me. On a needle crike, which I've never done, you're saying my dominant hand needs to be towards the head.
Towards their head.
And why?
Because if you think about your dominant hand starting an IV, because you're kind of putting a needle in at an angle, and you need it angled toward the patient's chest.
Oh, you got to have your wrist. Yeah, you got to turn it. Okay.
And so you're going to, I know this might be hard to visualize.
It's like starting an IV
yes,
backwards.
Yes. So, or starting an IV, an EJ.
Or an EJ, yeah.
An EJ. So think of that, because you want to position yourself for success, because trying to do it from the other way is going to be very difficult. You need a high pressure oxygen source, which most agencies don't carry a jet ventilator. So you're just going to do the best you can with your BVM and your adjuncts for that.
There are some tricks with oxygen tubing and stuff.
Yes.
You can kind of create a high pressured kind of a jet ventilator. I'm sure there's a YouTube video you could go watch, but actually, if you are going that method where you're oxygenating them straight from an oxygen tank, it's LPMs, you turn up 10 to 12, which gives you about, I think, 50 PSI.
There's commercial kits for them, but these patients typically have a full obstruction. So the idea is that the oxygen is not going to just go out their mouth, because that's why you put the needle crike in. But if they had an open space there, you wouldn't be able to put air into their lungs with this little catheter. You would just be pushing it out the path of least
possibly
resistance.
right.
Yeah. So
it really just depends on pressure gradients.
You need a 12 to 14 gauge over the needle cannula, and if you have the Pertrac kits, they come all kind of set up. It's what we carry. They have a adapter that we can put a BVM right on, and so
I've seen those. They're
nice.
nice.
Yeah, and then
rather than trying to cowboy it or MacGyver it,
it really
when you're in the middle of this panic
of a
situation.
child dying. Yeah, that's hard. And then the 3-way stopcock. I have never really played around with the 3-way stopcock. I've made things out of ET tubes and stuff, but the kits really are the way to go, I think. Complications are similar to other surgical airways, but this patient is at risk for becoming hypercapnic because they can't exhale like normal. And then know that they might get a pneumothorax or a tension pneumothorax, especially if you're using a jet ventilator. And the age of the patient, that can increase as they're younger. They're more susceptible to that. So that's all.
That brings us to the end. Awesome. Thanks. That was great.
Yeah, this is a good review.
Yeah, we'll see you on the next one.
Holy cow.